Awesome. So I'll start off by introducing myself. My name is Alice Spaccasassi. I am a communication consultant working with Abby at Transmission PR. Transmission PR is a PR agency that specializes in the inclusion of trans and non-binary people. And I will be your host for today. So I'm here with Dr. Giuseppe Di Taranto. Would you mind introducing yourself?
Hello, Alice, and hello, everyone. Thank you for the introduction. My name is Giuseppe Di Taranto, and I'm a plastic surgeon based in London. I currently work at Chelsea and Westminster Hospital, where I hold a substantive post in plastic and gender surgery. At Chelsea and Westminster, at the moment, we are building a new, fresh service of excellence for gender surgery. And I also have my private practice. I also offer a private procedure, private surgeries at the Cadogan Clinic in London and at the private wing at Chelsea Westminster Hospital.
Awesome. Thank you for that. So in the next hour, we'll be taking some questions that were given ahead of time and answering some kind of frequently asked questions about Giuseppe's practices and gender affirming care. And then after that, we will take questions from the audience. So make sure to ask your questions in the Q&A box. And even if we can't get them to your questions today, we will make a follow-up Q&A answering all the questions that were discussed today. And the recording for this will be available on YouTube later on. So don't fret if we don't get to your question right away. So let's start off from real softball, get everything going, Giuseppe. So as people may have noticed from how we both pronounce our names, we're both from Italy. Can you tell us a bit more about your background and kind of what you brought to the UK from your experiences in Italy?
And I need to specify that it's just a chance that we are both Italian.
Yeah, absolutely is, yeah.
So I come from the southeast of Italy, from a region called Puglia. But when I was 18, I moved to Rome, where I completed my medical school, my training in plastic surgery, and also a PhD. At the end of my specialization in plastic surgery, I had the opportunity to attend a fellowship in microsurgery abroad in Taiwan. Most of the people ask me why Taiwan. It was on the other side of the globe. But most of the people don't know that Taiwan, like Japan, is a motherland of reconstructive microsurgery. And reconstructive microsurgery plays an important, a very fundamental role for genital reconstructive gender affirming surgery. In Taiwan, I had the chance to work closely with living legends of plastic surgery, of reconstructive surgery, as well with young pioneers of microsurgery. And it was such an amazing experience because I was working with colleagues from all over the world. We were sharing experience, skills, and I had also the opportunity to know better the culture and the countries of Southeast Asia. So when I went back to Italy after this productive period, I thought that my practice would have benefit from another experience abroad. And this time I chose a country slightly closer to Italy. My first choice was the UK, as we have a really high consideration of the NHS in Italy. NHS for us is one of the best healthcare systems in the world. It's a model because it provides high standard of care while providing as well innovation and a lot of research opportunities. At that time, when I sent my first application, I got a one-year contract in the NHS, and I thought that I was coming to the UK just for a short period. Now, that short period has lasted for the last 4 years. And after familiarizing myself so well with the UK and working so nicely in the NHS, I decided to permanently move to the UK, where now I'm based, and I have a full-time job in NHS, and there's no chance to move back to Italy anytime soon.
I can relate to that a lot. I think it's a very common experience of moving from Italy to the UK for a short period of time, and then that just seems to expand quite a bit. Perfect. So actually, I'm really curious. Did the move to Taiwan happen in part because you were already interested in gender affirming healthcare specifically, or did you find your interest in that specific form of healthcare later on? When did you realize that you wanted to specialize in this?
So unfortunately, I didn't know much about gender surgery before going to Taiwan. There's a huge lack of training in the Italian medical school, but I've noticed also in the British medical school. So I came across my first gender diverse patient when I was in Taiwan. Especially in one occasion, we had a case referred to our unit, which was a unit accepting complex reconstructive cases. This patient was non-binary and was seeking gender affirming surgery. As no one of my immediate team had much experience working with this patient population, we sought help from a colleague, another fellow, who is a plastic surgeon specialized in gender surgery coming from Thailand. At that time, I was really impressed by the dedication, the knowledge, the skills, and the empathy that this colleague showed to the patient. And as well, I was very impressed by how amazed and how grateful was the patient after the surgery. And in that moment, I realized how this surgery can not only change patient's life, but complete patient's life, giving them the opportunity to move on and empower themselves. I'm particularly proud of the period I spent in Taiwan because I had the opportunity to know more about gender surgery, and also because I had the opportunity to refine my skills in microsurgery and reconstructive surgery, which again plays an important role in genital reconstructive surgery for gender affirming purposes. I had the chance to work with Professor Hun Chi Chen, who is a very renowned surgeon, microsurgeon, and I had the chance to perform phalloplasty, some phalloplasty, which is the main genital masculinizing surgery available. Since then, I have gone on to work with some very best surgeons in the field, like Professor Georgievich, who practiced between New York and Belgrade, and this gave me the chance to hone in my craft to where it is today. I work at Chelsea and Westminster Hospital now. As I said before, we are establishing a national center of excellence for feminizing and masculinizing gender affirming surgery. And here we have at Chelsea Westminster, we work in a multidisciplinary team with plastic surgeons, urologists, gynecologists, endocrinologists, psychologists, dietitians. We have lots of people. And our mission is to offer an holistic approach to our patient, providing continuity of care throughout the transition. We have also a GIC clinic, Trans Plus, and our goal will be to follow our patients from the first referral to the end of the journey, to the end of the last surgery.
That's fantastic. I can confirm from like my own personal experience that like having consistent care is a particularly valuable thing in gender healthcare. So that's fantastic. Awesome. I feel like it's quite a thorough introduction. Really got a lot of the previous experience and that stuff out the way. So shall we start with some of the like pre-submitted questions?
Yes, please.
Cool. So what types of top surgery for transmasculine individuals do you provide?
So for transmasculine patients, we offer a range of different techniques according to the patient characteristics and their expectation. For patients with a small to medium-sized breast, we offer keyhole mastectomy, periareolar, and butt wing mastectomy, which is an extended periareolar. The advantage of this technique is that it leaves a minimal scar just around the nipples. So the mastectomy is performed through a small incision that literally leaves the scar around the areola, which is the darker skin around the nipple, which tend to blend very well with the color of the nipple. For patients instead with a larger breast, we offer double incision mastectomy performed either with or without the nipple graft. The technique is ideal for those patients who have large breasts and also maybe they experimented skin weight loss, so they have saggy skin and they want to achieve a flatter chest. This technique allows for the removal of the excess skin and the breast, and also allow to tightening the skin of the chest. This surgery involves making two incisions, like the name suggests, double incision. So one incision at the top of the breast and one incision at the bottom of the breast, under the crease. Once we perform the mastectomy, we remove the breast and the skin excess. We then join the two incisions together, the top and the bottom, so that the final result is a single linear scar that goes from the midline to the side. During the procedure, we have also the possibility to reduce the size of the nipple and to reposition the nipple in a position that looks more in proportion with the masculine and a flatter chest. Of course, the disadvantage of the technique is that it leaves quite noticeable scar. But these scars, if placed in the line of the muscle, they tend to blend pretty well with the edge of the muscle over time. We also offer as well liposuction, combined with any of the technique that I mentioned before. Indeed, aside from the breast tissue, some patients come to my attention with areas of stubborn fat on the front or on the side of the chest. And often it's not possible, it's not easy to get rid of these fat pads, even with diet or exercise. As this type of fat, the growth of this type of fat is mainly hormone driven. So if we don't treat during the surgery these fat pads, they might increase the risk of developing what we call dog ears, which are skin excess, unpleasant skin fold at the edge of the scars. That, of course, might create deformity of the contour of the patient and might trigger the gender dysphoria. Also, if we don't treat these areas of stubborn fat, this bulky tissue might not match and look not in proportion with a flatter chest, preventing patients from wearing normal clothes or tight clothes or sleeveless clothes in the summer. The liposuction can be performed through the same incision used for the mastectomy, so it doesn't add any extra scar to the procedure. For the liposuction, we use very fine cannulas to aspirate or to suck out the fat. And also the liposuction have a minimal degree on the skin, because it might help the skin to shrink over time and improve the contour of the patient.
Fantastic. In terms of cost, how much can people expect to spend for top surgery, and does this change based on the type of surgery that is performed?
Yes, it changes according to the type of the procedure performed and the operating time required in theater. The procedure for transmasculine patients starts at 7,000 for keyhole surgery, and the double incision mastectomy starts at 9,000 pounds instead.
Perfect. In terms of binding, I know people will often be binding for long periods of time while they wait for top surgery. So do people need to stop binding before surgery? And if so, how far in advance before surgery day?
So it is highly advised to stop binding before top surgery, also because it's proven. Evidence shows that binding is not healthy over the long term. Specifically on the skin, binding and taping can cause inflammation and damage to the skin. Thus, it is highly recommended to stop binding at least 2 to 4 weeks before the surgery to make sure that the skin and the tissue are in the best possible condition for the procedure and reduce the risk of complications.
Fantastic. And once a patient has had top surgery, how long does the procedure usually take to heal afterwards? And just kind of, if you can give us some general information about the recovery process from top surgery.
So the healing time for top surgery can vary significantly depending on several factors, like the type of procedure that we perform, the individual healing responses, and the compliance to the post-operative care. If no complication occurs, so if the surgery has gone smoothly, the wounds typically are healed in 2 to 3 weeks. Then the bruising, the discomfort, the swelling, which are all expected from surgery, they should subside within the first 6 weeks. During these 6 weeks, we recommend the patients to wear a post-operative compression garment that we provide after the procedure, and to avoid heavy lifting or strenuous exercise. After the 6 weeks, the patient can gradually resume physical activities. But at the end, finally, it can take up to a year to see the final result and for the final result to fully stabilize. as over the following month, so beyond the 6 months, the scar will continue to soften and the skin settle in the new contour of the chest of the patient.
Fantastic. So it's good to find out the actual term for the compression garment, because I have had friends who got top surgery who just called it the last binder I'll ever have to wear. So
yes, that's what I tell to the patient. Is the last time you're wearing a binder in your life, hopefully.
Fantastic. So taking a step towards transfeminine gender affirming care, what type of feminization surgeries do you provide?
So for transfeminine patient and those looking for a flatter chest, we offer a wide range of options. The first and most common procedure offered to transfeminine patient is breast enlargement or breast augmentation with implants. The procedure involves placing a breast implant, silicone breast implants, to achieve a fuller and enhanced breast. The implants can be inserted through a small incision, which is typically placed in the crease under the breast or around the areola. The implants can be placed either above or under the muscle, depending, of course, on the frame of the patient and on the size and the outcome that the patient desires. There's also the option to perform breast enlargement without implants, with what we call fat grafting or autologous fat transplant. This technique involves using liposuction to remove fat, so adipose tissue, from one area of the body to the breast. So if a patient has area of fat that they don't like, this technique is useful, because it's very helpful, because on one side can address the excess fat on the thigh, on the abdomen, on the knees, on the back, and can also improve the size of the breast in one go. So we perform the liposuction first, and then we inject the fat into the breast. This technique is ideal for patients who would like to achieve a moderate increase in size. It's not the best option for patients who want a significant increase in the size of the breast. And has the advantage that uses own tissue, so natural tissue. Doesn't use this technique doesn't use foreign body that might need other surgery over time. I also offer breast reaugmentation or revision breast surgery. These type of procedure are advised for patients who had previously undergone breast augmentation, and they might need to change the implants because they might have experienced issues with an implant, like rupture or other complication like a capsular contracture, or maybe just because they are not happy anymore with the outcome of the breast enlargement. All this procedure can be also combined with a breast lift of mastopexy, especially in case of revision surgery. We might see skin excess, saggy skin, or patient would just like to have a tighter look or move the position of the nipple. In this case, we can perform a breast lift to improve the shape and the appearance of the chest.
And how much can people expect to pay for these type of procedures instead?
So the breast augmentation for transfeminine patients start at 6,000.
Perfect. And I think this is a pre-submitted question, but it's something that I've been personally curious about as well. What causes the prices for these surgeries to be what they are, right? Is there a specific thing behind it? Is it like an industry standard?
So for breast enlargement, the main factor that increased the price is for sure the cost of high quality implants. High quality silicone implants are quite pricey to produce and purchase because the brands that produce this type of medical device, they use advanced materials and the manufacturing process required to ensure safety and durability. We probably all remember the scandal of the PIP implants, which were silicone implants not made by medical silicone, but industrial silicone. So to ensure that we are operating at the highest standard possible, of course, we need to use implants that are medical device, and of course, they have a cost. For top surgery, we also need to take into account the time required for the surgery. Unlikely other type of surgery like breast augmentation, top surgery requires at least 2 hours. We often need to use large incisions, and that of course require more time and more surgical materials to be stitched up. Of course, the hospital fee and the fee of the clinic will reflect the cost of the operating time, of the use of the facility, and all the medical instruments used for this procedure. But what I can say is that the prices are quite aligned with the normal plastic surgery procedure that we perform for cis patients.
Awesome. That's I think exactly what a lot of people want to hear, is like, I'm getting the same treatment that cis people would. So in terms of gender affirming surgery, I think there is a lot of we're very culturally used to top surgery being its own thing as like gender specific healthcare. But I think that might be less true for breast augmentations. So it might be useful for people to know what the advantages of going with a gender affirming surgeon for breast augmentation are versus a general plastic surgeon.
That's a very good question. So first, I advise to all my patients to choose carefully their surgeon. I always advise to make their own researches before coming to the consultation, to ask for the CV of the surgeon, to ask for their result, because it's very important to establish trust between patient and the surgeon. And this empathy relation, this relationship of empathy will also help in the postoperative recovery. Specifically for gender patient, the WPATH, which is the World Professional Association for Transgender Health, according to the guidelines of WPATH, they recommend the chest surgery on transfeminine patient to be performed by surgeons specialized in gender surgery and who regularly treats transgender patients. And this is because transgender patients and non-binary patients have specific anatomical characteristics, and they have needs that differ from those of the cisgender patients. We, as gender surgeons, we also must to stay updated with the guidelines of gender surgery, stay updated with evidence from new researches and innovation in the field. And this will allow us to provide patients with the best standard of care possible.
Fantastic. I think that's a very succinct way to convey that. And in terms of breast augmentation surgery, I'm sure a thing you get a lot is what size should someone go for, or like up to what size can just a breast be augmented to, while obtaining kind of a natural looking or like a good result for the surgery.
Probably this is one of the most frequent questions that I receive at the consultation from both transgender patients or cis patients. It is important to understand that everyone is different. Everyone has their body, their own characteristics. So I have a lot of patients coming to the clinic, show me a picture of a friend or a picture of a lady that have a result they've seen on Instagram, asking for the same type of result. Everyone is different. What I say to them, it's impossible for you to achieve the type of look. Specifically for the size, it is important that the implants are not manufactured in bra-cup size, but they are measured in the volume of silicone that the implants contain. And any attempt to place a too large implant in the body of a patient for sure will come with complication, and ultimately with removing the implant because it's causing complication. Instead, during the consultation, after examination, after taking the measurements of the chest of the patient, examining the skin, the breast tissue, and the frame of the patient, I offer to perform a sizing test. In the sizing test, I ask the patient to try on in a sports bra sizes which are similar to the implants that we use in the theater. So at the end of the consultation, we can agree roughly on a size. We can agree on a size that roughly will meet the patient expectation. And together we can come to the best conclusion on the best fit according to the bodies, natural guidelines of the patient. So without any exaggeration that might not look in proportion, and especially might be not safe.
Fantastic. And in terms of feel and how the final result would look like, how natural can people expect that to be?
So right after the surgery, the breast will feel rock solid. They will be hard because there are a lot of swelling, there's a lot of inflammation. So patient might feel that the breast is very firm. But as the breast settles after the operation, the common expectation is that breast should soften, resulting in a very natural look and feel.
Awesome, perfect. We're going to move on to some more questions. I'd just like to specify that the next set of questions are both valid for transmasculine and transfeminine healthcare, just in case of confusion. So will people need to take time off work for the surgery itself and for recovery periods?
Yes, patient will need some time off. It's not a surgery performed under local anesthesia. The procedure that we discussed so far, they are performed under general anesthesia. And the body will take time to wear off the medication and to recover from such a procedure. The exact downtime depends on multiple factors, of course, including the type of the procedure, the patient fitness, and the type of work. Most of my patients, they take about a week of work following surgery and they are fully recovered. However, if patients has an extremely physical job, then they might need a longer recovery, a longer time of work. Or they might ask as well to their employer to be assigned to light duties only. Anyway, after the procedure, I will provide individualized advice on the best timing for return to work. And I can also issue a sick note that might support at the time of work for your employer, while maintaining the confidentiality by not specifying, of course, the nature of the procedure.
Perfect. And in terms of age for patients, is there a minimum or a maximum age that you require of patients to accept them for surgery?
As I mentioned before, and probably I will mention again in this interview, we must follow international guidelines. And in this case, we follow the WPATH guidelines for safety of the patient. And the international guidelines for gender surgery states that patients must be of the age of the majority of the country where surgery is performed to be fit for having surgery. So specifically for the UK, it will be 18. Until that age, I encourage my patient minors and parents and relatives and their carer to seek counseling and, of course, medical support until the age of the majority.
Awesome. Do you need any referrals to accept a patient? If so, what kind of referral is that?
Again, according to the guidelines, we required a single referral letter from a licensed practitioner. And this can be a psychotherapist, a psychiatrist, who is accredited as a gender specialist.
Okay. Yeah, I get the impression that people looking to learn more about gender affirming surgery will hear a lot about WPATH guidelines. And what are the waiting times?
Yes.
For
So the waiting times for a consultation at the moment is 1 month, and for surgery 2 months from the initial consultation.
Awesome. Very manageable compared to the NHS waiting lines for anyone who's currently on them. And I guess more in broader questions about gender affirming healthcare in the UK, not so specifically about your practice, but why do you think that waiting times for gender clinics for GSCs are so long?
That's a very good question. Unfortunately, we all know that we have long waiting list for the gender clinic in the UK. There are different causes that might be behind the long waiting list. For sure, we have limited resources. In the UK, the GIC clinic, they operate with very limited resources, including shortage of funding, shortage of specialist staff, such as endocrinologists, surgeons, and mental health professionals. We also need to consider that there has been an increase in the number of people seeking gender affirming care, which definitely at the moment exceed the capacity of the existing clinic to provide timely services. The NHS at the moment is working with new different providers and has created pilot studies to open new gender clinic all over the country. TransPlus, for example, is one example of a successful pilot study that we inaugurated at Chelsea and Westminster. There is also a need of more professional interest and trained in gender affirming care. Trans health care at the moment is not included in any curriculum of medical schools or any training for healthcare professionals. In my hospital, we have a gender service, so we provide all the staff with an induction about transgender healthcare. But in many hospitals, there's not even an induction in the beginning about about the needs of transgender patients, what are the possibilities, what are the cares required in this field. I think that there's a lot of work to do. There's a lot, of course, to do in terms of advertisement, this field of medicine. If a medical student like I was is not even aware of the existing of this field of medicine, how they could ever become interested? How can we ever gather enough people to build together new clinics and new services all over the country? There's a lot to do. NHS is really interested to expand the service and creating more opportunities. We work together to improve the situation. Hopefully we will get there.
Fantastic. In terms of preparation for surgery, there's a lot of differing opinions in trans spaces, and I think also confusion sometimes by GPs in terms of what hormone profile is needed to prepare for surgery. So is it true that you need to have, for example, testosterone, a masculinizing hormone therapy for a certain amount of time before getting top surgery?
For top surgery, this is debated, but for top surgery at the moment, we don't need the patient to be on testosterone. Instead, for patients who are seeking genital affirming surgery, specifically for masculinizing genital affirming surgery, it is highly required for the patient to have been on hormones for a recommended period that usually is 2 months or more. And this is not just a criteria set in stone by the international guidelines. This is because if the patient has been on testosterone, the testosterone has the possibility to enlarge the tissue of the patient, and this give the surgeons the possibility to work with more specimen, with more material, healthier material, providing the patient at the end with a better outcome. For a trans feminine patient, it is recommended for breast enlargement. It's not mandatory, but it's recommended to have been on hormones for at least a year to enlarge in order to have a breast enlarged and more tissue to work with. For the feminizing genital surgery, instead, it's a mandatory requirement to have been on hormones treatment.
Fantastic. Now, I think we've covered all of the pre-submitted questions. Please tell me if I'm wrong. I can't see any more on my sheet. So we can open up the, just find myself again. We can open up the Q&A session from the audience. And I think we have a new question right now, which is about healing. As a male to female diabetic with a rubbish immune system, would this significantly impact after surgery care? Some from previous operations, bracket broken bones, I have experienced longer healing periods. Would this be costed beforehand, or could I see significant further costs?
So if the diabetes is under control, and of course, if a patient is diabetic, we will need blood test and we will need further evidence before booking the surgery. If the diabetes is under control, the chance of healing well should be similar to those of the general population. Of course, if there's any complication after the procedure, this should be included in the aftercare. So I wouldn't expect any extra cost.
Fantastic. I think that's very reassuring for somebody preparing for a surgery like this that also requires a recovery period to know that. We have also a new healing question. It's understandably a very big topic, I'm sure. I know that C-sections can affect the core muscles long term. Are there similar long-term consequences of top surgery for trans women?
So, for the C-section, the incision goes through the muscle till the uterus. So this creates an area of weakness in the core muscle that over time might create long-term consequences, like a syndrome called floppy wall. For the top surgery, instead, first is not 100% sure that we are going to disrupt the muscle, because the implants might be placed over the muscle, so not touching the muscle at all, if the patient has enough thickness of the tissue on the chest. In case we need to place the implant under the muscle, first, we don't place the implant completely under the muscle. We do what we call dual plane technique. So we place the implant partially under the muscle, so the muscle will cover the upper pole of the implant and the breast tissue will cover the lower pole. We don't completely detach the muscle from the chest. We only detach few fibers of the muscle from the lower part. And this might create a discomfort at the beginning, might create a bit of weakness in the first few months, but once the body adjusts with the implants and with the final result, it shouldn't create any long-term complications.
Awesome. Perfect. So, I think previously you mentioned that you do revision surgeries for patients who have come to you previously for masculinizing or feminizing surgeries. However, are you willing to perform revisions from operations done by other surgeons?
Yes, I currently accept patients also for revision from other providers, both for feminizing or masculinizing top surgery. For feminizing surgery, normally the dissatisfaction is related to an implant that is old and is ruptured or has been dislocated and might require adjustment. For top surgery instead, the main request is to adjust the result in larger patients. As I mentioned before, not many surgeons might perform the liposuction or offer liposuction with top surgery. If we leave the area of fat around the chest, might not look in proportion. I have few patients coming to me because they still not feel comfortable in their own body. They don't feel comfortable to wear tight clothes. And some of them, they even might go back to the binder. So yes, I offer and I accept patients from other providers for improving their outcome and making them feel better with their own body.
Great. And in terms of potential complications, both for top surgery for transmasculine and transfeminine people, what are kind of different complications that may arise, and kind of which ones are realistically more common than others?
So, top surgery and breast augmentation are both common procedure, and of course they share the surgical complications of any other surgical procedures, like infection, bleeding, hematoma, and seroma, which are fluid collection in the wound, blood clots, wound dehiscence, delayed healing. These are common procedures that we might encounter even after removing a small skin lesion. Specifically for the top surgery, we have a complication related to the nature of the procedure, especially in case of a double incision mastectomy with the nipple graft. We need to take into account the chance of losing the nipple necrosis. I try to explain to my patient that every time that I transplant a nipple is like I'm doing the gardening. I'm moving a plant from a pot to another, and the plant needs to make the roots to survive. If the plant doesn't make the roots, of course, it's going to die. Anyway, if this happens, we offer the patient potential solutions like another surgery for reconstructing the nipple or the possibility of having a 3D tattooing. Patients for transmasculine patients having top surgery, they also need to consider the sensitivity of the skin over time. Most of the patients, they lose the sensitivity of the skin, which eventually come back over time or might not come back. So it's very important to consider the erogenous sensation, the tactile sensation of the skin. Another common complication is the abnormal scarring. Some patients, they are prone to develop very thick scars called hypertrophic scars or keloids that might require further treatment in the future. For breast enlargement or for feminizing top surgery, of course, we have a specific set of complications related mainly to the implant and the procedure that we are performing. A capsular contracture is a quite common procedure quite common complication over the long term, and it involves the formation of a thick scar tissue around the implant. When this thick scar tissue occurs, the breast might feel non-natural, might feel very firm, and it might even distort the shape of the breast. So in that case, we need to replace the implant and remove the scar tissue around the implant. The implant also might rupture or leak over time, and in case of a rupture, we need to replace the implant. Most of the brands that are available today on the market, they provide also a life warranty on the implant. So in case the implant gets ruptured, the brand will provide the same size of implant, included in the original cost of the implant, of course. The implant might move, and they might drop or might dislocate. And if they shift or become displaced, this might require a small surgical revision to replace the implant, position it in a better position so that it might look more even with the other side.
Great. Also, because you mentioned it, and I think fewer people are aware of it than they should be. If people in the audience have not heard about nipple 3D tattooing, it is fascinating part of gender affirming healthcare. I recommend people Google it, look it up. It's very interesting. So for patients with a higher BMI, would you still offer to perform top surgery? I know this can be quite a debated aspect of gender affirming healthcare.
So patients with the stable BMI and no other medical issue can be candidates for the surgery. Of course, I believe more in the fitness of a patient for surgery rather than the number itself. BMI is a useful tool to quickly evaluate of a patient, but it's not always very reliable. An example, someone who goes to the gym often, work hard a lot, and has a lot of muscle. Of course, that patient might be overweight, and the BMI might tell us that they are not fit for surgery because they're overweight, although being very fit. So the BMI can be helpful, but again, is not always the best number that we need to look for. Patient before the surgery then needs to be fully evaluated in terms of comorbidities, medical issue, and any medical problems. If they smoke, if they take any medication, all this together will tell us if the patient is fit for surgery or not. It's not just the number. It's not just the simple BMI result that we have. And of course, we need to consider that once we operate in any facility in the UK, there are the criteria, the guidelines that we need to offer. So up to 40, I assess the patient and I evaluate if they are fit for surgery. And normally, I provide a supportive letter for the medical director of the hospital to have a surgery that, of course, is an elective surgery, but it's not cosmetic surgery. It's a life-completing surgery. Over 40 BMI, there are restrictions in most of the clinic I work in London. And of course, these restrictions are made for patient safety, because operating on a patient over BMI without having an intensive care facility might be very risky. So in that case, I recommend a patient to a dietitian service. I recommend a healthy lifestyle, a weight management program to help the patient to get fit for the operation. And normally having this operation, it's a great motivation.
Fantastic. In terms of your approach to drains, would you like to talk a bit more about that?
Oh, I perform top surgery and almost any type of feminizing chest surgery as day case procedure, as I strongly believe that patients recover better in their own place, in their own bed. As part of this enhanced recovery approach, I discharge patients who have having top surgery with very fine drains. And I use the same drains I use for facelift patients. So they are extremely, extremely tiny drains. The use of drains reduces the concern about potential fluid collection like seroma, hematoma, which are quite common in the literature about top surgery and might require another operation. The drains are removed at the first follow-up appointment. And also, if the patient had a liposuction, the drain is a very useful advice. It's very useful tool, because after the liposuction, there's a lot of fluid leaking from the wound. And this might help to keep the wound dry. It will help to seal the wound and help the skin to settle in the right position.
Great. In terms of the different types of surgery you offer, which ones are also offered by the NHS?
So top surgery is currently offered under the NHS, but as we discussed before, the request, the demand, unfortunately, is not cannot be addressed in a timely manner, because we don't have many centers performing top surgery at the moment. The NHS, unfortunately, traditionally doesn't fund breast augmentation or feminizing chest surgery. There are some channels to make a special request if patients believe that an exception should be made in their case. This type of request is called IFR, individual funding request, and can be found on the website of the NHS. It's quite tricky. The accepted rate of these requests is very low, but anyway, it's worth the try.
Amazing. It's always worth a shot to try and get some support for stuff like this. I agree. And in terms of what a patient can do to improve the result of these surgeries, what can patients do?
So my advice for patients is to get fit and have a healthy lifestyle before the procedure. So for sure, stop smoking and stop vaping, because any nicotine product can significantly increase the risk of complications and hinder the skin's ability to heal. So patients are advised to stop smoking 4 weeks before the procedure and to avoid any nicotine product, again, 4 weeks after, so before and after the procedure. I also recommend to keep hydrated, to maintain fit before the procedure, avoid any aspirin or any vitamin, any supplements for the 2 weeks before the procedure, because this might increase the risk of having bleeding.
I think also specifically for scarring, do you have any advice in terms of maintaining the quality of the scars, like sunscreen, avoiding exposure to sunlight?
Yes, absolutely. All my patients after being discharged from the wound care, so from the appointment with the nurse to check the wound, are sent a leaflet about how to manage scarring with all the advice, how to massage the scar, what products to use, and how to cover them from sun exposure.
Awesome. That was a lot of information. But a lot of time questions can be very specific, or we might have missed something. So if anybody in the audience has anything else they'd like to ask Giuseppe, this is the time to do it. And we'll wait a second now to see if we have any more requests.
Yeah, we are surprisingly quite on time.
I do my best.
You've been great. Thank you.
Also, for anybody who might have missed something earlier, or for those joining us later, we will be adding this online on YouTube, so you'll be able to jump back to specific bits. Don't feel any pressure to take thorough notes from this call. And any kind of useful link that we've discussed might be available in the description for convenience as well. So. Perfect. I'm very impressed. That was very on time. You're right. Okay.
Thank you, Alicia, for hosting this wonderful Q&A. And again, if patients or anyone from the community have questions, we are happy to reply to all of you. And you have our contacts, my website. I'm happy to give advice in any case. Thank you.
Amazing. You can, if you have any questions, you can reach Giuseppe at info@mrditaranto.com. So that is info, info at Mr. MR DITARANTO.com. I'll make sure this is also available on the YouTube video description for anybody who's listening to us in a recorded format. And we will also make sure to answer anything that we might have missed in a frequently asked question blog that will be coming out shortly after this is uploaded online. So again, thank you so much, Giuseppe, for your time.
Thank you. Thank you.
And I hope you all have a lovely evening. Thank you for joining us today.